good afternoon. Thank you for attending this month's My Wellness Update presentation. Today's presentation will be on suicide awareness, Let There Be Hope, presented by Tanya McFarland. Tanya has a master's in social work and is a licensed social worker. Tanya joined Reid in 2006 as a discharge planner. Tanya also worked in psychiatric services as an outpatient therapist and on the inpatient psychiatric units, then transferred to the EAP program, or the Employee Assistance Program, in 2013. Tanya has experience working with individuals, couples, families, and children by assisting them with addressing issues from behavior concerns to mood disorders such as anxiety and/or depression. Please welcome Tanya.
Well, I want to first thank everybody for coming. I'm going to try not to go far away from the microphone because I was already warned that I didn't want to wear that thing that you have to wear in order to be heard. But I want to thank everybody for coming out. This is a really difficult topic to discuss. And the reason that we want to discuss this is because it's a big epidemic. It's going on. And it's kind of one of those, the big pink elephant we don't want to talk about, but it's so important that we do talk about it. And get that out there to start raising awareness so we can help our fellow community members in society. So first, what I want to start off with is give you a little, is that better? Can you guys hear me when I'm over here too? Okay, a little bit better, okay. I want to start off through this presentation, we're going to learn that every 12.8 seconds, someone in the United States commits suicide. So I have my Vanna, I have someone that's going to be doing a chime. So if you hear a chime every so often, that's just every 13 minutes. Just to put it a little bit more in perspective on what we're facing and kind of what we're dealing with. The information that I obtained through these statistics mainly came from the Center for Disease Control and the American Foundation for Suicide Prevention. So we want to face the facts. In 2013, that was the last full data that was available for this reporting of suicides. 41,149 suicides were reported in the United States, which made it the 10th leading cause of death among suicides, which equates to every 12.8 minutes, someone dies by suicide. And when we break it down to that, to me, I think that's a pretty impactful statement. Therefore, why it is so important to bring awareness out there so we can try to do what we can to help save. The highest suicide rate was among people ages 45 to 64, and the second highest was age 85 and older in our older adults. White males counted for, and this is still the national statistics at this point, again from 2013, white males accounted for 70% of all suicides. The suicide rate for males is 4 times more than females. However, females attempt 3 times as more and as often as males. The most common method is firearms. Second is suffocation, which we would include hanging in that category. And third is poisoning. And that's overdosing, carbon monoxide poisoning, and different things like that. The most common for males is firearms, and for females is poisoning. Now, a lot of times when it comes to the poisoning and overdoses, we have more of an opportunity to be saved and live. And firearms, not all the time, but most time is what's going to make it completed. And so I don't know if with that statistic of males are 4 times more than women to complete suicide and have death by suicide, but women attempt 3 times more as often. In 2013, our Indiana statistics, we had 944 suicides reported in that year, leaving Indiana the 25th ranked state, which out of all of our states, I feel like that's a pretty significant here in Indiana that we do have to deal with. The second leading cause of death for ages 25 to 34 was death by suicide. The third leading cause were for ages 10 to 24, was death by suicide. The fourth leading cause was for ages 35 to 54. The eighth leading cause was ages 55 to 64. And then the 17th leading cause were for ages 65 and older. And on average, if we look at just the state of Indiana, one dies by suicide every 9 hours. So if you think of our work shift, just about one work shift a day, someone dies in the state of Indiana by suicide. So I want to talk a little bit about facts versus myths. Myth, suicidal people are fully intent on dying. We have what's called suicide ambivalence, which means a lot of folks are undecided whether or not they want to die or they want to live. They just don't know how to go about, and they feel like death is the only way out of their pain. And so if we can make people more aware and help about what is available out there to them, we can try to get these numbers to decrease. And so a part of them wants to live, however, death seems like the only way out, and they may leave themselves to gamble with death, which means it leaves it up to other people to save them. Another myth, people who talk about suicide do not complete suicide. Many people who die by suicide have given definite warnings to family and friends of their intentions. And always, always, always take any comment about suicide seriously. I know sometimes we might get involved with some individuals that might say it or talk about it, but ask. It's hard to do, but ask. Asking a depressed person about suicide will push him or her to complete suicide. They're already thinking about it. So us asking them is not going to push them any further because they already have ideas and minds in their head. Studies have shown that patients with depression have these ideas about talking, and it does not increase the risk of their own life. Again, it kind of helps them look like, oh, someone's paying attention and maybe someone cares, and maybe this is my reach out. Maybe this is who I can contact for some help. Another myth, suicide occurs in great numbers around the holidays in November and December. That's not a myth. Most of the suicides occur early on in May or June, while the lowest rates are actually in December. Improvement following the suicide attempt or crisis means that the risk is over. No. Someone that's struggling with suicide typically has another mental illness that is with it, whether it's major depression, bipolar, substance abuse. And so it's not over. That episode might be over, but we still have to be concerned and make sure that they're getting the right treatment that they do need. Most suicides occur within days or weeks of improvement when the individual actually has the energy and motivation to actually follow through with his or her suicidal thoughts. The highest rates are immediately after a suicide or a hospitalization for a suicide attempt. A lot of times folks, if they have an attempt and it did not complete, they go through many different emotions, whether I failed, why couldn't I get this right? Oh, here goes another thing. And so it adds on to it. So when they go home and they don't have the right support, they don't know where to turn. And most likely they're going to try it again because I don't know any other way out. Risk factors. We want to look at previous attempts. Have they had previous attempts? History of depression or other illness, mental illness. And so we have a higher risk if they already are dealing with a mental illness. That just increases it for them. If there's drug or alcohol abuse, family history of suicide or violence. A lot of times if we've experienced someone in our family, even close friends, it increases our risk. Financial or relationship issues, lack of social support. A lot of times people are feeling alone. We have barriers to care. Can they access their care? How much is their care? Is there help to get their care? Because unfortunately, it's not a free service. And so the only thing that can be free is what we can do as society with each other is help them out and help them get to where they need to be. Physical illness. If someone deals with physical illness every day, and I don't know if anyone in here, and you don't have to raise your hand, but if you deal with chronic pain, you know it weighs on your mind. And there are some days that you feel like you could just explode, and some days you just don't know what other way out. Feeling alone, and environmental stressors. So depending on what's going on, whether I have a job loss, retirement. A lot of folks that go through retirement, they start thinking, oh, here's my next stage of life. What does this mean? Because after retirement, what happens next? Typically, a lot of individuals know with the life cycle what goes on after retirement. And unfortunately, at this day and age, we are working a lot longer than what we had to 10, 15 years ago even. So some warning signs that we want to look for are if the individual is talking about killing themselves. They might make little comments of, it'd just be better if I was gone. Having no reason to live. They can't find anything to live for. They might have children, but they can't see the fact that the children need them because their pain is over exceeding what their resources or what is around them that might need them. Being a burden to others. You hear this so often. As caretakers, I know I have some nurses and some medical staff in here. How often do they say, I don't want to be a burden, or I don't want my family member to help because it's just going to burden them? But what we need to do is say, you know what? If they didn't want to do it, they wouldn't do it. And helping them out and understand that not everybody thinks it's a burden. Feeling trapped. So feeling like there's no other way out again. This is the only thing I can do, or I get stuck in such an emotional pain, I can't think clearly. All the great coping skills that I might once been able to use, I forget them. They're out the door. Because at this point, this is my focus. Whatever situation that I'm faced with right now, I can't seem to get past. And a lot of times we don't want to reach out and ask for help because we don't want people to know we're struggling. Especially if we are in a professional world, we think, am I weak? What are they going to think about me? Are my coworkers going to be looking at me? Are my friends going to view me differently? Will they not want to be around me anymore? So the biggest thing is, I just won't say it, therefore if they don't know, I can still have that. And unbearable pain, whether that be emotional or physical pain. We want to look at some behaviors. If they have an increased use of alcohol or drugs, that's a pretty big sign. If you notice that friend or family member are increasing their use. Looking for or researching ways to end life. So a lot of times individuals might get on the computer or internet and start looking at how much carbon monoxide would it take for me to put my hose in the truck? How long does it take? What kind of carbon monoxide would I need to use? What level would I need to use? Look at those kinds of things about what are they researching. Look at the history. If we have kids, if we have spouses, anything, look at the history and make sure, what are you looking up? I'm just concerned. Acting recklessly. A lot of times people might become more sexually promiscuous. They might drink and drive and not care. They might do things illegally. They might decide, oh, I'm going to steal. They do reckless behavior because at this point, they're still contemplating, what do I want to do in this reckless behavior? That might give me a lead to where I want to go. And so we want to pay attention to that. Withdrawing from activities. If you notice someone that once had an interest in playing board games and no longer they want to play board games, that's a red flag. Just start paying attention. If they wanted to go out with friends all the time and now they do not, it's a red flag. Just look at what are they withdrawing from activities that they once really loved. And that could be a little bit different if we have a physical pain. If I like to go out and play basketball, but I can't because I broke my leg and crutches aren't really a good idea to go out and try to play basketball, no. But on other things, if one person loved to go to movies all the time and there's nothing preventing them from going to that, why don't they want to go to movies anymore? Why don't they want to go on that Wednesday night get-together that I always did with my friends? We want to look at isolating from family and friends. A lot of times, if I don't want to know, I might be afraid. We might be the person that carries our emotion on our sleeve, and we know that. Or we have that family member or friend that can look at us and say, what's going on, and I'm not ready to face that. Then we might isolate from them so I just don't have to deal with it, or I just don't have to explain. Or I don't know what to say. And if I just don't talk to them, then we'll be okay. I won't be okay, but they'll be okay. Sleeping too much or too little. A lot of times if we find that they're overly sleeping, and this is not medication-induced or anything like that, but we find that they're sleeping a lot more or they're not sleeping enough, then that's another warning sign. Visiting or calling people to say goodbye. A lot of times, if they're really at that end, they might start trying to mend relationships at one point that they didn't. Or if they haven't talked to a parent and they decide, I'm going to call my parent. I love you. Just going to say goodbye. I might not tell you exactly what I'm doing, but I want to say I love you. I haven't talked to you in a while. I want to get to hear what you're doing, how you're doing. Because a lot of times people want to know that people are going to be okay afterwards, but we're in that moment that we can't think about how everybody else is going to respond because we're only stuck in our own darkness that we cannot see how it may affect others around us. Giving away prized possessions. So if you have someone that has some prized possessions and they start giving them away, be cautious, ask. Because typically, unless they're going through a yard sale and they need to get rid of stuff, but if they're starting to give away their prized possessions, really pay attention to what might be going on with them. And aggression. A lot of times they're angry, they're mad, they have a tornado of emotion inside their mind that I don't know what to do. And almost like a child, I'm going to act out. I don't know how to tell you what emotion I'm feeling, but I don't care, and I'm mad, and I'm going to act out. And so if you find someone becoming a little bit more aggressive, we want to look at mood. Are they in increased depression? Are they sad? Are they crying a lot more? Are they withdrawing? Loss of interest. Are they not doing the same activities that they once loved to do? Is there rage? Are they having these bouts of increased rage where they're throwing things around? Irritability? No. That can be hand in hand. We can look at other things that can create irritability for us, like everyday stressors at work. But when this irritability stays and lasts a lot longer, we want to look. Humiliation. They're embarrassed. A lot of times, again, they don't know if they really want to die, but they don't know any other way out, so they're humiliated, and they don't want to talk about it. Anxiety. If you see an increased anxiety, because again, their wheels are cranking on what should I do? Should I do this? Should I not? When's the time? And then you'll start seeing some of these bottom, irritability, rage, humiliation, anxiety, become more and more heightened because, again, they're in that tornado emotion in their mind and they don't know what to do. Health. We want to look if the person has a history of depression, bipolar, schizophrenia, borderline or antisocial personality disorder, conduct disorder, psychotic disorders or psychotic symptoms in the context of any disorder, anxiety disorders, substance abuse disorders, and serious or chronic health conditions and or pain. Again, if someone's dealing with a lot of pain, they have a hard time, and I want the pain to go away. I've been into doctors 10 years. They can't figure it out. I'm in constant pain. This is my only way out. We want to look at environmental issues. Contagion would include exposure to another person's suicide or too graphic or sensationalized accounts of suicide. Media is a big part right here that talks about suicide and brings it around, and it starts making people, especially with the younger population, if we have something in schools go on, then a lot of times young kids, unfortunately, almost jump on that bandwagon. And they look at, oh my goodness, I'm feeling this way. Is this what I should do? And unfortunately, we have kind of peer pressure, or we follow along with what people do. So again, if you have a suicide, for instance, Robin Williams, no one expected, happy, always wanted to make everybody else happy, made everybody else laugh, but again, torn up inside so much that it brought about, oh goodness, if he can do it, maybe this is what I need to do. We want to look at access to lethal means. Do they have guns available? Do they have medications available to them? Do they have any access to the means that they plan on using? And so if you're talking to them and they're giving you ideas of what they're thinking of how they may do it, if one says, you know what, I'm thinking about hanging, okay, where's your belts? Where's rope? Where's a place that you can do it? Ask those questions. They're more than willing to tell you what they are, and they realize, uh-oh, someone is paying attention, and maybe there is help out there. Prolonged life stress factors, harassment, bullying, loss of job, retirement, any of those things, and stressful life events, divorce, death, and again, a loss of job there. Historically, we want to look at, is there a family history of suicide? That raises your risk just about, I don't know if I want to say doubled right there, but if you have a history of family suicide, then you're more at risk, at a greater risk for you to think about suicide. Family history of mental health conditions. And so if you deal with family members that do have a mental illness, it's hard. How do I help them? How do I get them out of this? And sometimes we take on that sole responsibility of we have to be the ones to do it. We can offer that support and help, but we want to look at what the family history is and what kind of mental health condition they have, because a lot of times mental illness can be genetic, and so we want to look at that. Family history of previous suicide attempts. And so whether or not a family member actually was able to complete a suicide or attempt a suicide. And a history of child abuse that increases the risk, and if there's a warning sign that someone had been abused as a child, there's a greater risk that they could be contemplating suicide when they get older. Socio-demographic, things we want to look at, male, over age 45 to 64, white, separated, divorced, or widowed, living alone, being unemployed or retired. Occupation, I want to say health occupations are at higher risk. And with those listed, and I was like, what? With these listed are dentists, doctors, nurses, and social workers. And of course, those are the ones that are typically dealing with a lot of this stuff and see a lot of this stuff. And whether or not they get debriefing counseling afterwards or whatever they need afterwards, they're trying to deal with what's being brought at them too. Therefore, it increases their risk a lot higher. And it's especially high in female physicians. So we want to look at some protective factors. What can we do that kind of helps protect the thought of death by suicide? So we want to look at individual and public awareness. The primary risk factor, again, is psychiatric illness. So we want to look what's their history with that illness. And depression is treatable. A lot of times, I don't know if anyone's ever had to deal with depression. You don't have to raise your hand. But if you've dealt with depression, even a situational, it's hard. When you're down and you're feeling down, again, it looks like there's no other way out. And it just kind of, we just get stuck. We want to destigmatize the illness. Unfortunately, in this day and age, we still have a stigma about mental illness, and that is bad. You know, we can say, I've been diagnosed with diabetes, or I've been diagnosed with high cholesterol, and we have no problem saying that. But if I say I've been diagnosed with depression or bipolar, we tend to want to hang our head down because it's still stigmatized. And we need to try to do what we can in society to break that stigma in order to have people freely open and talk about it. We want to destigmatize the treatment. When we go seek treatment, a lot of times we don't want anyone to know that we're getting treatment again. Again, if someone finds out that I'm getting treatment for my depression, if I'm getting treatment for substance or alcohol abuse, if I'm getting treatment for anything that would be considered a mental illness, then what are my friends going to think about me? What are my coworkers going to think about me? Are they going to see me as weak? Is my boss going to think that I can still do my job and perform my job at a level if they know I'm dealing with this? And so it goes back to that stigma. Encourage help-seeking behaviors and continuation of treatment. And so help individuals find, okay, what can you do? What has something that worked for you in the past? Who are your support systems? Who can we reach out to? Some more protective factors is problem solving and conflict resolution skills. My coworker Susan and I do two trainings a month on conflict resolution skills since February this year, and we just got a schedule that we're going to be doing it for a whole another year next year, 2 a month. So welcome to that. But what we want to do is help people get and gain that knowledge of how do I appropriately problem solve? How can I step back and look at my situation? Again, if we're depressed and we're down, we don't really think clearly and see clearly. We think on this long spectrum between rational and intellectual, but I always say emotional, and this might be a little side note. I had several clients come in, and no offense to males by all means, but when I said rational and intellectual, a lot of males were saying, see, I'm smarter. And I thought, okay, I'll get myself in trouble for that. But really, we think on this long spectrum. And if we're very emotional about something, is it a good time to make a decision about what we're going to do? No. Because I can tell you, my checking account has been overdrafted, but I go into Hoppy Jewelers and I see a ring I really want. Well, my rational side says, I can't get that. I can't afford it. My irrational side says 6 months, same as cash. I can get a car, and that ring is going to look good. It's not the best time for me to make a decision. We want to look at strong family and community connections. So if we can get individuals see what their social supports are. If we can get them to, if they're good, strong bonded with their family, but they might be isolating from them, help them reconnect with that family. A lot of times what we have to do in our line of work is bring family along. We need, obviously we get the permission, but we say, you know what, with what you're going through, I need someone else. I need someone that can be there. I'm not here 24/7. I need someone that can be there that can help me identify what some of the problems are or what they may be seeing as a support system. And community connections. What's available to them? A lot of places, community mental health centers, if insurance doesn't cover or if we're struggling paying, they have a sliding fee scale and they'll work with you on that. Just let them know what's going on and try to get to that best option. Access to effective clinical care for mental, physical, and substance abuse disorders. Again, we struggle with that as a society, and I think insurance plays a lot of piece of that, is what they're willing to cover and what they're not. But going back and saying, what do we have access to? And again, a lot of places will work on payment plan, do a sliding fee scale, different things like that. So we want to look at what access do we have and what barriers do we need to get to those access. And so we'll act sometimes as an advocate, just as every one of you would work as an advocate if you had a family member in a hospital and you didn't think things were going right. If you had a family member in a situation that you didn't think they were being treated right, you would sure jump up and want to be an advocate for them at that point. And then we look at cultural and religious beliefs. Culturally and religiously, what are their views on it? What happens? There's many different religious and cultural beliefs. So what happens in there, get their input and perspective on what happens in that case. How do you feel about that? And get them talking about it. Get them talking about, is it acceptable or whatnot? And I use acceptable as a loose term because in their, you know, in individuals' mind, they're going to rationalize why they feel the way they feel and the thoughts that they're having. They're going to rationalize why they're having those. So we want to look at road to recovery and what some of the treatments are. One, antidepressants. And so antidepressants, we want to adequately prescribe treatment and monitoring. Only 20% of medicated depressed patients are adequately treated with antidepressants, and possibly due to side effects. I don't know about any of you, but a lot of times I don't want to take a medication because the side effects is making me funny. If we're on an antidepressant medication, our libido goes down. That's going to create, or could possibly create, issues in our personal relationship. And so we look at how are the side effects. It makes me too sick. I get a headache every day. It makes me too jittery. So therefore, I just want to stop and not take it because maybe I can deal with this pain more so than this side effect. Lack of improvement. So maybe they're taking the medication and it's not being improved. One thing I like to say about antidepressants, and I don't know why some physicians or just why some physicians don't come out and say this, and I learned it actually from a drug rep. When you're taking any kind of psychotropic medication, antidepressant, anti-anxiety, the best thing is within 30 minutes, if you smoke, and I don't know if we have any smokers that take medication, if you smoke, caffeine, coffee, anything like that, don't take it within 30 minutes of taking your medication. Because what's happening is the medication is fighting for those same receptor sites as that nicotine is, as that caffeine is. And I'm telling you, the nicotine and caffeine will beat it every time. So a lot of times I know with my clients that I work with, and we work on medication, they're saying, it's not working. I ask, how are you taking it? And I have them just do that one little shift adjustment of not taking it within a half hour before or after of taking that medication, and we find some improvement. And so we want to get the most effective. If we're going to take medication, we want the most effective way that it's going to help us. High anxiety not treated. A lot of times, you know, unfortunately, in this day and age, we have a lot of people that are seeking for some kind of substance that can get us high, in a sense. And so we're really standoffish about prescribing some things. Or if I'm dealing with anxiety, a lot of times depression and anxiety go hand in hand and can mimic some things. And so if we're dealing with a lot of high anxiety and we're not being able to deal with that, again, it puts us right back into, I don't know what else to do. Fear of drug dependency. So do I have to take this for the rest of my life? I don't want to have to take this for the rest of my life. And a lot of times when it comes to individuals that might have schizophrenia or bipolar, if I'm starting to feel good, I don't need the medication anymore. So I'm going to stop. I'm going to stop taking it. And then when we stop taking it, we just start sinking and going back to it again, not realizing that that medication was helping. But again, if I had diabetes, I would have to be on medication most likely for the rest of my life. But that seems to be societally more acceptable than having to take a mental illness type of medication. Substance use. A lot of times if we're using substance uses as a coping skill, along with our medication, that's going to counteract what the medication is doing. And so we have to watch, what are we doing, and are we increasing our substance use? And if I'm increasing my substance use, take that step back and say, why? What's going on? What am I trying to cover up in that sense? What do I not want to face, or what's hard for me to face? Didn't combine with psychotherapy. And so sometimes we get medications, but I don't need to go talk to someone. And a lot of times you have an 80% improvement if you do the two back and forth. And Susan, remind me, I don't think that number really has changed yet as far as statistics and research. So 80% more effective if you combine both an antidepressant with psychotherapy. Does not have, or your dose is not high enough, so we're not working right now with a correct dose. So calling your physician and saying, hey, I don't think this is working. And unfortunately, and I don't know if any of you had to deal with it, but unfortunately when we're changing meds, sometimes we feel like a lab rat. Sometimes we feel like, we're going to change this again, or this isn't going to work, or I've been put on this. And it's frustrating, and we just get to that point where we're ready just to give up. Didn't add adjunct therapy such as lithium or Abilify. So a lot of times if we have an antidepressant that's not working quite well, we need that booster. And sometimes giving those boosters help, but we don't always get those. And it's hard, I don't know about anybody, but it's hard sometimes going into a physician office and trying to get everything out that I need to say within the time allotted that we get. And so usually by the time I'm walking out of there, I think of the 50 questions that I had in the original visit, and now I'm stuck. So I'm like, oh, well, I'll just wait to see what happens. And then a lot of times it becomes too late, or we're frustrated and we're ready to just be done. Didn't explore all options, including electroconvulsive therapy, which we call ECT, or other somatic treatments, like we have up in our EAP, biofeedback equipment that we can hook you up. It monitors your perspirations and heart rate and different things like that. And it's a technique that can do a lot of relaxation techniques for us and help us be more aware of our body, our mind, and spirits with that. And neurofeedback. Neurofeedback is another option that we do not do, I know here, but in the community, they do have individuals, and if anybody needs anything, please email me afterwards, and I have some business cards. That way you have my email address or phone number that you can contact me with any questions. Psychotherapy, to be effective, it must be specifically designed to treat depression, relatively short term, so about 10 to 16 weeks. It should be structured, which means when you give them something to do, it should be able to be followed step by step if another person went to another therapist, and they would be able to follow that step by step. Examples of some of the psychotherapy is cognitive behavioral therapy, where we look at our thoughts and our emotions along with our behaviors and how we can interact and interfere and change some of our behaviors and change some of our thought processes. Interpersonal therapy and dialectical behavior therapy, DBT, and this is one of the top and most preferred type of treatments for individuals that are dealing with personality disorders. So we want to look at prevention. What are some things that we can do to prevent? Now this is more societal role, so we want to do firearm safety and make sure individuals have safety of firearms if they have access to them. We want construction of barriers at jumping sites. And so if we know, and again, I know this is a lot of community issues where this is going to have to resolve from. But if we have easy access to jump wherever we need to, we're more likely to do it. But if we have something that we have to, an obstacle or whatever that we have to get over, it's going to be harder to do that. Detoxification of domestic gas. Improvements of the use of catalytic converters in motor vehicles. Restrictions on pesticides, and reduce lethality or toxicity of prescriptions. And so for doctors that are prescribing, maybe using lower toxicity antidepressants, changing the packaging of medication to blister packs, as you have to pop them out. I don't know if anybody's seen a blister pack, but instead of giving you a bottle of here it all is, here's a blister pack, you pack one out each day, and it just kind of comes. And sometimes they only bring you, if you get involved with a community mental health center, sometimes they only bring you that dose for that day. And we want to look at restricts sales of lethal hypnotics and the barbiturates that are more deadly. So you can help. And ways that we can help is show you care. Take all talk of suicide seriously. If you have someone coming to you and they're talking suicide or they're kind of making a threat, sometimes we get mad and we just might threaten suicide to kind of get what we want out of something. But unfortunately with that, my thing is take all suicide seriously. And if you have to and you have a real concern about someone, call your local police and say, I would like a wellness check. I would like for you to go check on this person because this is what's been said to me and I'm not quite sure and I'm not comfortable. So is there any way that you can go do a wellness check? Listen carefully. Listen to what they have to say. A lot of times individuals in this manner, again, they're lost, they don't know what to do, and we want to try to fix things. You know, if someone comes to us with a problem, we can list 5 things of what they should do in order to fix it. Well, again, these individuals are lost in a tornado of emotion. So if we go on and sit there and try to tell them what they should be doing or what they should not be doing, here we go back to saying, oh, I'm weak, or oh, I should have known about this, and I'm no good, I'm hopeless, and going back to that manner. So we want to make sure that when we listen, we just listen, because sometimes that's all they need is that ear. Reflect what you hear. So whatever they tell you, reflect it back to make sure you're hearing them correctly, and that we're not assuming that by making a negative comment, or what we might appear as a negative comment, we might say, oh, or we don't want to listen, we just don't want to listen to it because how do I get involved in what I do, and I don't know if I want to be responsible type of thing. And so reflect what you hear to make sure you are hearing what you think you are hearing. And then use language appropriate for the age of person involved. So you're not going to use the higher words that a young kiddo's not going to know what it is. Another thing, when we go back on destigmatizing everything, when someone says completed suicide or successful suicide, they look at those as, I don't want to necessarily say derogatory words, but words that can hinder. So what they look at is saying death by suicide. It's easier to hear, and especially if we're someone that has dealt with someone that died by suicide. We don't want to hear say, oh, well, they committed suicide or they did this. Changing the verbiage to it's death by suicide. It also makes that more easier, I think, for families and survivors of a suicide victim that, you know, they're struggling, they have lots of questions why too. And so changing a little bit of that verbiage. We want to be genuine. We want to let the person know you really care. We want to talk about your feelings and ask about his or hers. And when I say talk about your feelings, it's not about in depth about how you're feeling. It's, I'm worried about you. And so I care. I want to know what's going on. Or it really scared me when you made this statement last night. It's those short details or short little excerpts that say how my feelings are, but not in depth of what your feelings are about the situation or anything like that. It's, you're really scaring me and I'm concerned. Ask about suicide. Be direct but non-confrontational. We have to watch our tone sometimes. It's not what you say, how you say it can make a difference. And so if we have an individual that is talking about suicide, we want to say, have you thought about killing yourself? What are your plans? Do you have access to those plans? What's it going to be like? What would you have left? Who's going to be left? Just asking those simple things about, let's get it out there and let's let them know that we're okay talking about it and it's not that pink elephant in the room that we just don't want to face. Ask about treatment. Are you seeing a family physician? Are you seeing a psychiatrist? Are you seeing a therapist? Are you taking medications? Ask any treatment you can about that's going to help get you to where you need to be to help this individual. Get help, but do not leave the person alone. And so if you have an actively suicidal individual, never leave them alone. So you can keep them with you right then and there. Call about any resources that might be possible or available to them, but never leave them alone. You do not need to solve all of the person's problems, which, again, that's hard. If someone comes to us a problem, we're pretty quick at saying, well, have you did this? Have you looked at this? Of course, it's our way we might be thinking about doing things and stuff, but you don't have to solve their problem. You just have to engage them. So some questions that you may want to ask is, are you thinking about suicide? What thoughts or plans do you have? Are you thinking about harming yourself or ending your life? How long have you been thinking about it? Have you thought about how you would do it? Do you have guns in your home available? Do you have access to your prescriptions and medications? Ask about any type of lethal means that they may have access to. And do you really want to die? Or do you just want the pain to go away? And a lot of times you might find, I just want the pain to go away and I don't know how to get it to stop. And therefore we can jump in and say, you know what, well, I have some resources and let me try to help you out. Reassure the person that help is available and that you will help them get help. Again, don't leave them alone. This is important as, oh, I'll help you and walk away. Well, what's that going to make them feel? Well, they really cared. And are they really going to come back? And so, again, let them know what's out there and how can I help. Encourage the person to identify other people in their life who can also help. So do we have friends, family, church members, anybody that can help you get through this, or that we can say, you know what, let's bring them in. Can we let them know how you're feeling? And that'll give yet another person to be able to support or kind of monitor. We want to outline a safety plan. So make arrangements for the helper or helpers to come to you, or you bring the person to them. Again, don't let them alone. Once therapy or hospitalization is initiated, we want to make sure the suicidal person follows through with appointments and medications. Now, it doesn't mean you have to take on the sole responsibility, but if they're if they're hospitalized, make sure their discharge appointment is set up. Make sure they have a way to there. Make sure that it is something that they can financially afford. And so again, just kind of making sure that you're able to help and kind of monitor what might need to be done and offer that support. So I want to end with a real good quote that I had come across that I thought was pretty impactful and important. Was suicide. Suicide is not chosen. It happens when pain exceeds resources for coping with the pain. And so with this, there are several different resources that are available to you. The first one is the National Suicide Prevention Talk Line, which is 1-800-273-TALK. Get that out there and let individuals know. Now on the back, I do have pamphlets that have this lifeline number on there, along with a veteran's lifeline and a Spanish-speaking lifeline to get that. 911. Well, we have Suicide Prevention Online, or suicidepreventionlifetime.org. That is in online. They give a lot of different resources, a lot of different warning signs, and a lot of different things that we talked about today that can maybe help better understand or make it more clear for you. Call 911. In an acute crisis, call 911. Always get someone involved where they can do the steps that they need to do in order to get the person help. And really that's taking them probably to the emergency room to get evaluated, and most likely they're going to be assessed to see how safe they are, and then what can we do to help them. Call 211 to find local therapists and doctors. Everybody heard of the 211 resource line that you can do? It's been out there maybe a year-ish now, a little over a year, but call 211 and you can ask about anything. What doctors are in my area available? Where are food pantries at? Where are clothing shelters at? Where's a domestic violence shelter? It's a great, great place to call that gives you a lot of resources if you're unsure. The American Foundation for Suicide Prevention, they do trainings, they do educational classes, they do all kinds of different things. They set up walks. I know Indiana has their chapter, and if you get on the American Foundation for Prevention Suicide, you can find your local chapter and how you can get more involved. The Center for Disease Control, they're the ones that give us a lot of the statistics, and again, they give some hints and ideas of what we can do and how can we make it better and make society better for that. And then Indiana has a suicide prevention plan. I brought a copy here with me. It's a more in-depth plan, and it's just targeted by the state of Indiana in order to give different resources. And if you get a chance, look up that packet. It has stories from individuals all throughout Indiana that was willing to share their experience and how they were going, how they dealt with it and went through. But there's also, in this plan, it breaks it down by minority group, age group, and many different things like that that give you a little bit more statistics and what we can do as society to be able to help, and what we can do, actions out there to get involved in order to help this epidemic, this topic that's going on. Now with that, does anybody have any questions? Yes?
Can you go back to the picture before the end when you said suicide is not chosen, it happens when?
Yes. This one right here?
No, it's probably right there now.
Okay.
Okay, that's what I wanted.
Yeah. When I came across it, I found that it was a very powerful, because a lot of times when we think about it, we say, well, what do you mean it's not chosen? They chose to do that. But again, I take it a step further and say, they don't know what else to do. So do they really want to do it? A lot of times, no. But again, their pain is exceeding any of the resources that they feel are available to them. Because I go back to they feel all alone. And so it's hard when we have that stigma against mental illness and getting any kind of treatment for it. A lot of times it's easier for us to just kind of duck our head and figure out how we're going to do with it on our own, and how can we go and try to cope through this and manage on our own, which a lot of times we need help. And it's hard to ask for help, but it's important to be able to ask for help. With them not being willing sometimes to ask for help, that's where as a society we can jump in and say, ooh, I noticed some things are going on, or I noticed you haven't wanted to play volleyball and you used to play every week. Is there anything going on? How can I help? Type of thing. And so this goes back to the resource page, and we're going to put, Cheryl, I'm not sure, are we putting it on the shared?
Yes.
Yes? Okay. I have the PowerPoint, so if anyone wants to email me privately or have any questions, absolutely feel free to, and I can send that over to you. We're going to try to put it on the shared drive. I don't know if everybody knows in order how to get that. But that's always an option. And like I said, I'll leave some of my business cards on the table. That way, if anybody needs any, I can get you my contact information. Is there any other questions? Yes.
I was surprised to hear that suffocation was so high on the list of ways to suicide. I don't think I've ever heard of anybody committing suicide by that.
It's hard, and in suffocation, it does include hanging, which is one of the most popular causes as far as when it comes to suffocation. Unfortunately, a lot of our teenagers are playing the pass-out game. I don't know if anybody's ever heard of the pass-out game, but it's where we decide to get into the closet and kind of choke ourselves until we just barely pass out, but then we can wake up, and sometimes it goes too far. And hence where that one became a little bit more as that second leading cause. Anybody else? Thoughts? Statements? All right. Well, I really appreciate you guys coming. and hearing this. Like I said, I know it's not an easy thing to do. It's not an easy thing to talk about, but as we can see, it's important we do talk about it and get that out there. Okay. Well, you guys have a wonderful afternoon.